Welcome to a Shot in the Arm podcast. I'm Ben Plumley, and this is a podcast about innovation and equity in global health. We're recording this podcast a few days before many involved in the fight against infectious disease are going to be coming together, Canadian visas permitting, in Montreal for AIDS 2022 to take stock of the AIDS response, particularly after the last 2 years of COVID and in the light of the new monkeypox outbreak. Well, a Shot in the Arm podcast will be there. We'll have daily episodes, and I'll be joined by friend of the pod and fierce South African activist Yvette Raphael to look at where the science is heading and what the priorities are, particularly around the need for much greater global attention to optimizing effective diagnostic networks, which are essential backbones in bringing current and new pandemics under control. And I'm hugely grateful to this episode's sponsors, Roche Molecular, and particular because they've given me the chance to chat with two of its top physicians, Tamar Tchelidze and Ben Lebron, both of whom have had fascinating and hugely important careers in the response to infectious disease. Tamar, Ben, welcome to A Shot in the Arm. Tamar, perhaps I could start with you. What do you do at Roche?
First of all, thank you so much, Ben, for inviting me. It's an absolute pleasure for me to be here today. So I work at Roche as a disease area partner focusing on infectious diseases and more specifically virology and transplant. And just to very briefly mention that this position, the disease area partner, is the key role that brings our medical and scientific affairs strategy to life for clinicians and patients.
Now, you and I actually have a bit of a similar history, don't we? We've both participated and negotiated closely in UN declarations. You most recently at the UN Summit on Universal Healthcare as one of the lead negotiators for Georgia, your home country. What was that like? And I guess my big question for you is, how did you survive the experience?
Yeah, first of all, thank you for this question, Ben. And indeed, it was fascinating to hear that we crossed our paths by participating in UN resolutions, very particular experience. First, and one of the most important things I want to mention, it was a very rewarding experience. As I realized from the very start that it could make a huge impact on our society. As we all know now that, not now, but some of the people maybe know that the health is the human right. And everyone should have the access to the services, medicines and vaccines at the time when they need it. And UN is the place where the politicians are coming, and such decisions could be made in the form of, for example, the resolution. Of course, then comes the next part, that the resolution and the resolution should be implemented in the respective countries for such as UHC. And in terms of the second part of the question, how did I survive? I think largely because that. It was just an incredible feeling of being part of something this magnificent and being able to contribute. I also cannot stress that I had enormous support from my colleagues at WHO, also my Georgian mission itself and the Thailand mission, because Thailand and Georgia were two co-facilitators of this resolution, and of course the member states. And I want also to shout out about Japan, because they're champions in this regard, and they actually were also very supportive through the process. So I think that made us, and there was a momentum. So we were so happy, even if we left very late most of the days, the missions. But yeah. So.
Yeah, especially if you didn't get any sleep during that time. I know that well. And we're also joined, and I'm so thrilled because I've been really wanting to get Ben Lebron onto this show. Benjamin Lebron, and of course I'm a Benedict, so the two Bens. Now, Ben is the founder of Floating Doctors, a non-profit medical team that works with coastal relief agencies, established coastal relief agencies, primarily in Central America on the Atlantic side. And I think what is so interesting about Floating Doctors is that they don't tell these relief agencies what they need to do. The relief agencies tell them what they need, and then Ben and his colleagues deliver that, and all by boat. Ben, welcome to A Shot in the Arm podcast. Have I described floating doctors right?
Fairly accurately. We do try to not, kind of go, what you should be doing is, which is a really annoying phrase, that people in the humanitarian world often hear from other well-meaning people. We ask what's needed and then we go and do it. And what's often needed is the most basic access to primary care and referral services and diagnostics, which of course are the gateway to treatment for everything.
Well, terrific. And you joined Roche Molecular last year, I think, like Tamar did. What's your role at the company?
So I sit in the global medical affairs position, primarily working on developing new HIV and hepatitis tests and kind of acting as the intersection between, kind of the scientific community who kind of, work with our tests and elimination programs and local stakeholders.
So we're recording this just before AIDS 2022. It's the Saturday, and literally just hot off the press, we have the news that Dr. Tedros at WHO has declared monkeypox a global health emergency. And I don't suppose we can really do any podcast about global health without addressing monkeypox up front. And Ben, I don't know what your thoughts are, your reactions. Have you actually encountered monkeypox in your practice over the years?
I've never actually encountered it before. And I'm kind of looking at our current response and, very low scale of testing. It's early in the pandemic. There's long lines of people trying to get vaccines. New York State Health Department is prioritizing vaccines, first dose vaccines for people who haven't had it, even if they're not sure that those people are going to be able to get a second dose, or the people that already had it would get a second dose, even though the FDA and CDC are advising them something differently. So I feel I have a strange sense of deja vu, for about 2 years ago right now.
Yeah, right. I mean, it's and not just 2 years ago. I mean, I'm seeing people like Peter Staley, the folks from Prep for All, who are taking us back to the early days of the AIDS response. And I guess the one of the critical issues is going to be around stigma and discrimination and whether we prioritize those most at risk. I mean, Tamar, your sense?
Yeah, so I think I agree with Ben largely, especially with the deja vu. But what I want to add here is that first, I'm happy to see that it's declared earlier than we experienced with COVID, which means that we may not repeat the same mistakes that we did and the panic and different type of messaging. I think the messaging to the society is extremely important, so we do not lose the trust. That concerns also the scientific community because, sometimes you're saying something or publishing too soon that, also interferes with the trust of the, also scientific society. But like you said, Ben, stigma also, it kind of comes into this as well. So that at least, I had these feelings and I really want to see that everybody is treated equally also in terms of, how we wording things, how we, getting the messages across the society. So, but again, I'm happy to see that we're acting on it, and I hope that we will take the lessons from the previous experience and do it right this time.
And I am sure that this is going to be something that is going to be top of mind in Montreal at AIDS 2022, which brings us on to the conference. And I guess my question for you both is, what are you most looking forward to? Data presentations, satellite meetings, networking, cups of coffee? What are you most excited about?
I can go first. Yeah, I'm actually very excited to go for a number of reasons. This is one of my favorite conferences. I'm very passionate about infectious diseases and very specifically HIV/AIDS, and that's the place where all these people from all around the world, the people meaning scientists and clinicians and public health professionals coming and sharing the experience. What I'm looking forward now is to really share the lessons and best practices because we've gone through a lot, especially with COVID, and COVID and HIV also has so much in common. And I wish that we have looked differently before and so really learned the lessons from HIV and implemented in COVID. So I'm looking to see how the countries really coped with the epidemic and what lessons they learned and shared that best practices and experiences. I also want to see how they're addressing the HIV transmission decrease, what kind of strategies they have, how they're really reaching the last people meaning in some of the even thriving countries like United States, we have some problems reaching those people that needs to be reached, whether it's treatment or whether it's screening or whether it's in terms of the HIV or whether it's prevention. So all of those, I would say, Ben, to network with people, to chat, to learn, and all of the areas. Of course, I want to see the new researches and new best practices. And
what about you, Ben?
So for me, this will actually be not only my first time at this conference, this will actually be my first time at a large infectious disease conference like this. For 10 years, I practiced almost exclusively off the grid in the middle of the jungle, in Panama and the indigenous reservation there. And I didn't really have either the financial wherewithal or, opportunity to attend conferences like this. So, I'm finally going to be, surrounded by other, infectious disease, specialists, other, activists, advocates, especially people working to really try, people who are really committed to trying to end this epidemic, to turn this, kind of unfortunately, maybe a little forgotten disease these days, legitimately into a rare disease. And I'm very interested to see what kind of innovation and ideas people have, and especially what Tamar said, reaching that last mile, that last group of elusive, challenging to reach patients.
Yeah, and that's particularly the case for the US and the industrialized world. Now, for me, the most exciting thing about these AIDS conferences, and Ben, I extend the offer for you to join me on a walk round. It's the community village, the global community village, where organizations of nonprofits, community-based organizations, even small networks and large networks get together, and they have their own sort of mini conference that takes place there. It absolutely influences and drives the main agenda, but there's so much vitality and life there, and I find that being there really reinforces. It's like a long shot of caffeine. So that's what I'm looking forward to.
I will definitely take you up on that. That would be awesome.
But look, it's our first in-person AIDS conference since COVID. Of course, the one previously was cancelled and had to be virtual. And I'm thinking of a remark that my friend Michelle Barry from Stanford University said. And she was an a really ardent advocate for cancelling the first infectious disease conference after COVID broke, and that was the CROI conference on retroviruses and opportunistic infections, because she couldn't think of a greater calamity than the bunch of the world's leading infectious disease experts, policymakers and activists coming together at what might be a super spreader event. And I know that many of A Shot in the Arm's listeners and viewers have wanted me to ask people what their thoughts were about this. Are you worried about something similar happening in Montreal? And what protections will you be taking? Particularly, will you be wearing a mask?
So, I think that's a very valid concern. Anytime 8,000, 10,000 people from all over the world travel through international airports and then gather together under one roof, you're really setting the stage for, creating possibly a super spreader event. It may be a little bit different now in terms of I'm guessing the vaccination and boosted rate among, these attendees is going to be fairly high, hopefully. I did attend a conference earlier this summer in London, and I did know there was not very much masking, and as a consequence, a number of people that I knew of actually did contract COVID there. So I just received my fourth booster, before attending that, and I wore a mask. I like to be a man with a belt and suspenders. And I think this is one where, especially infectious disease people, people working with infectious disease, infectious diseases, we really do know how to be responsible about protecting ourselves and others. And I do think it is important, that we try and set an example. And I'll certainly be wearing a mask, under any circumstances in which I might have proximity or which I might, be, conceivably, placing people or myself at risk.
What
and I hope
about?
other people will.
Sorry, Ben. What about you, Tamar? Will you be masking up?
Yes, and this is a very good question, Ben, and especially what we've seen also in the past. In fact, I was going to CROI meeting. I was in a cab and really thinking, should I be going? And that's when I was at the time working at the UC Berkeley, when my colleague called me and said, it's canceled and you need to turn around. So she knew that I was driving to the airport. So, and I was really happy and thinking, okay, thanks God, because I don't think, even though I was so excited to go for another reason, obviously. So the answer to this will be that yes, I will be masked. My experience also, I attended the ASM meeting in West Palm Beach also recently, and it was a requirement that we had to be masked, and most of the people were masked. And I hardly heard, even a lot of us actually from Roche attended, that anyone really got COVID, and I think that was primary reason too. Other precaution, all of us know kind of how to assess risk, right? So especially us in infectious diseases. So if you are near to someone that has chronic infection, like chronic conditions, or like elderly in your family, you should be extra careful by testing yourself more frequently. I'm taking actually tests. We have our wonderful also test that I can have with me and test it very frequently, whether I catch COVID or not. But I'll be masked, yes.
Well, and then getting to the actual science, I wanted to just get your thoughts on some of the data and the attention that I think is going to be very interesting, and it's all around the use of long-acting injectables of antiretroviral medicines. And basically, this really represents a move from popping a pill every day to having an injection every month or every few months. And this could be both for treatment or as PrEP, as prevention, pre-exposure prophylaxis. And I think that has the potential really to make huge, huge impacts in the way we manage HIV, assuming we can get the access questions in developing countries right. And I just wondered from you both how you see diagnostics being a part of this, because obviously if we are injecting antiretrovirals systemically into someone and they're having a longer effect than needing to be taken daily, things could get very interesting and complicated. So I just wonder what your thoughts are about where diagnostics fit in to this brave new world.
I can go first. Diagnostics in general, and we all agree on that, has play a crucial role at every step of the disease management, which includes the screening, the diagnosis, monitoring, and prognosis, of course. And HIV case is no different. In fact, we like in this field to talk about the care continuum, which status natural continuum actually. So, which means that we need to screen the person, identify whether this person is infected or not, and link them. If they are infected, link them to the care, and if they are not infected, link them to the PrEP. And this way, really, maintain to decrease the HIV new cases numbers down. Now, no matter which way we go, whether we link the person to care or to the PrEP, we need to do the testing. So testing is an absolutely first step, and not only as first step and to screen someone, but also to monitor the person, and especially that is. the case during the PrEP, whether you are on oral PrEP or cabotegravir, which is the long-acting, but the frequency differs. When you are on oral PrEP, the recommendation is to do the testing every 3 months, but if you're on cabotegravir, then the testing is every 2 months. So absolutely, testing is a must. So we have to, be very well prepared and aware what kind of testing also. It's not only the testing, because that's nuances that we are also, working very hard, along with CDC to get the messages across the healthcare providers and educate the patients as well.
Yeah, and I want to come on to that in a bit more detail. Ben, your 38,000 foot level about how the long-acting and diagnostics will work together.
So for me, and especially with my background, it's such a game changer. If you've got someone who's employed, college educated, they have a good paying job, they have health insurance, they see a billboard, they get tested, they come up positive, they get on treatment, or they go, I'm a little at risk, maybe I'm going to get on PrEP or talk to my provider. A lot of those people have been gotten already. And what I always think of, from the high level is, what about like my indigenous patients who are scattered across 10,000 square miles of jungle with no roads, no transportation, no communication infrastructure at all? I have patients, in that area with HIV, and it is so difficult for them to, be able to adhere to, their treatment, and especially now that PrEP is just starting to be available at all in that region. And very, very difficult, for patients to actually be able to come in, to take a pill every day, to come in, really frequently. So the longer acting PrEP, it's just so critical, and I think it's really going to be a game changer. But without appropriate testing, you can't implement it well. So you've got this awesome tool, but one of my board members always used to say, if it can't be measured, it can't be improved. If we don't know your viral load, we can't adjust your meds. If we don't know the prevalence, then we can't, adopt policy responses. And so this is where not only is testing, diagnostics, the gateway to everything. It's not just the gateway to treatment, it's the gateway to knowing what kind of treatment strategies, what kind of intervention strategies are going to work at the local level, the regional level, the global level.
So and also, I'll just add one moment. I'm sorry, Ben, to the Ben's points that, undiagnosed patients, and it's very particularly relevant now, can unknowingly transmit the disease to others, right? And also, early diagnosis can help to prevent or even stop the outbreak. So it's testing is absolutely critical.
Yeah, this isn't about just managing the epidemic. This is how we end it. We have to know who has it. So we have to know who has it, and we have to be able to put people on PrEP safely and effectively in order to stop this. And without diagnostics, we can't do any of that.
So I'm finally getting a word in edgeways. Thank you. We had such a brilliant conversation preparing for this podcast. In many ways, I wish we could have just recorded it. And you are both hugely passionate and informed about the role that diagnostics had to play. Tamar, you spoke about something that I'd love to get you to break down for us. I mean, and excuse me for asking a few stupid questions here.
There is no stupid question, Ben.
Oh, you'd be surprised. Diagnostic pathways, the backbone to an AIDS response. Obviously, you need to know you're HIV positive. You need to know how much virus is in your bloodstream. But could you walk us through what you mean by a diagnostic pathway?
What I previously said on the diagnostic pathway, I would bring it back here, which is absolutely crucial, which is the status neutral continuum again. So the testing is number one, and that's the diagnostic pathway to identify, screen someone, and then link to the appropriate place, whether it's care or the PrEP. But also, it is very important to bring here I think that what you are referring to, Ben, is the AAA plus S that I mentioned during our conversation. So when we are doing any big projects, the public health project, it's extremely important that we, strategize well from the start, and also think of the access, availability, affordability, and also equally importantly, sustainability. That's why I say AAA and S. And if any of those are missing, or for example, it's accessible but not affordable, then you cannot really do anything. Or if all the three A's are there: accessible, affordable, available, but down the road in a year, it's like this project or program is not sustainable, then we come back to the same issue. So it's collective effort. It's, of course, the political will, number one, that we have to have political will to change something. And I always say, I can't really stress enough that we need the paradigm shift. Anything we do, and especially in infectious disease, it's not incremental change, changes, but really to like a swift changes, like paradigm shift. And, always keep in mind those three A's plus S. And I can't stress access, whether it's medicine, whether it's services, whether it's vaccines, for everyone, and at the time when they need this. And one last point, because sometimes people think, oh, does it mean the free services? How can you get the free? How can some of the countries survive, giving some of the free services? No, it's not free. It should not drive people to the poverty, because we saw that even pre-COVID, I'm sure you know these numbers, but I just want to, bring it back here. 100 million people before COVID were pushed to the poverty because of, because of the problem of accessing the medical, because of the accessing medical care. So this is not acceptable. At that time, it was also said that if we continue the same speed, 2/3 of the people will be, driven to the poverty or having this problem. So we definitely need to make, swift and big changes and collective.
Yeah, and Ben, my sort of second stupid question is to you. I think many of us, jack of all trades policymakers, maybe don't really fully understand what a diagnostic, the implementation of effective diagnostics should look like. I mean, I think there's a touch of us that we all think it's a bit like Star Trek with a what is it, a transcorder or something that you can just get everything you need through a point of care test. If you were to walk us through what it happens after someone has their blood drawn in order to, one, know whether they have HIV, and then that's someone who does have HIV and is on treatment and then comes in and has their blood drawn to see how much viral load, how much virus they have in their bloodstream. How does all of this work? What happens behind the scenes?
So this is where the context in the developed world takes for granted that there's a certain level of infrastructure that exists that allows, as you say, all of this backstage, behind the scenes stuff to just happen. So you go into lab or your doctor's office and you get your blood drawn. And in the US now, a patient wouldn't think about what happens after that. And usually neither does the physician. It gets picked up, the blood gets sent to a lab, something happens to the blood, and then a result comes back, and the provider, and the patient can then take the next steps. But both in the US and in a lot of other parts of the world, it's not always as simple as that. The blood has to be once the blood is drawn, then it has to be kept in cold chain storage. It has to be centrifuged. It has to be sent somewhere while maintaining it to a certain temperature, where it can be tested. That laboratory has to be maintained, certified, people trained. I mean, there's this massive amount of behind the scenes infrastructure that has to exist. So when people are making policy, it's often really tempting and seductive, really, to forget that all that stuff exists and create policies for areas that don't always have that. And not just in the developing world, but in more rural parts of the US or underserved, metropolitan areas of the US. And they go to put policies in place that aren't practical because they address one part of it. Like, we're going to send all of these tests there, but without addressing the fact that there's no way to get the blood from where it's drawn to the laboratory. And so this is, where diagnostics, needs to not just include here's the test. Diagnostics also, I believe, needs to get involved in the practical strategies under a variety of circumstances of how to implement those diagnostics in a meaningful way, which is always more complicated than we'd like to believe.
Do you know, it makes me think. I mean, so many of us thought that with the emergence of point of care testing, where basically you almost have an on-off answer, somewhat like the home tests for COVID that we have, that would be the end of it, that would cover the diagnostic question. But that isn't the case at all. And I think there are huge implications for global access strategies. It's really made me think. But Tamar, if I might come to you, we've spoken about the US and that the needs are still very much there in the US, in marginalized populations, in those last mile communities. What do you think are the obstacles to getting policymakers, providers, and indeed patients aware of what needs to be done from a diagnostics pathway perspective?
There are so many barriers. We really need to get everybody together, like the main like policymakers, the other main stakeholders, like whether that's governments, whether that's community activists, or like the agencies. I did mention government, of course, the also the industry, to really think together and help each other out. Because as I said, there are quite a number of barriers. For example, the information and the knowledge, whether that's healthcare providers or patients. More specific example. So we know that the CDC just released these new guidelines, the PrEP guidelines, that we're thrilled to see because it has so many improvements, and the PrEP, as cabotegravir is also considered, and possible adverse events if particular diagnostics are not done. And also guidelines says that anyone who can prescribe PrEP, who can prescribe, who has the right to do the prescription license to have the prescription to do the prescription can prescribe PrEP. But those are people that we need to educate. Those HCPs, nurse practitioners, have never done this before, so they have to know not only how to prescribe or which PrEP to prescribe, but also how to do the diagnostics. That's absolutely crucial. So also we see other barriers such as stigma still. You will be surprised here in the US to see what is the level or the, how many people are stigmatized still, to mention that, they want to get on PrEP, because maybe we need to also, revisit some of the wordings that we've done before. Ben Lebron and I were discussing the other day, maybe just saying somebody is at risk is not a good word, because maybe that's not the very positive, way of asking people, are you at risk? Does it really mean that it's something negative? Because some people perceive that way, and maybe that prevents them to have the, conversations with the providers. So also there are some challenging algorithms for many that needs to looked at, and we need to help these algorithms to carry the message for the primary care physicians now and the other people that will be prescribing PrEP and monitoring for PrEP. Also, we see that there is some lack of experience and confidence in those people to do so. So a lot of things needs to be done.
Thanks, Tamar. And Ben, if I could ask you to pick up on that. So education issues with practitioners, and as you've both pointed out, these may not be in centers of excellence. These prescribers may be in rural communities. They may be general practitioners. They may be nurse practitioners. But there's also education around payers and policymakers. Yes, I mean the US is extraordinarily complicated when it comes to financing healthcare. But how is the understanding in the different groups of payers playing out? Do they understand the role that diagnostics need to play? And frankly, are they paying for it?
So a really good question. Tamar and I learned a lot about this, a lot of which was sort of surprising, over the last few months, when we've been really trying to dive more deeply into this and see where the disconnects are occurring. And, really reinforcing what Tamar said, increasingly it's primary care providers, and increasingly not just primary care physicians, but nurse practitioners, APNs, PAs, who both have the right and the opportunity to really prescribe PrEP. But I actually saw an interesting article from last July, so fairly recent, looking at what kind of PrEP education is provided in medical school, and essentially, very telling that this article was actually in the Journal of Primary Care Community Health. I thought was very interesting. And it said, also, I'll summarize by saying woefully inadequate. They were saying it's really inadequate, and the few schools that were really emphasizing this found that their graduates were far better prepared, to really help the 1.2 million people who could benefit from PrEP actually get on it, instead of only the 50,000 or so that are actually taking it right now. And when it came to the payers, we found a really big disconnect. In speaking with infectious disease specialists, heads of programs, people that really knew, we found that there was, both at the primary care level and often at the specialist level, a real assumption that certain tests in certain scenarios that are federally mandated to be paid were not being paid. That these claims by physicians were being denied, and physicians often were trying to appeal it, and with their tiny limited bandwidth, trying to go through that process. And we found that what was, at least one thing that was happening, was a lot of the payers weren't updating their payment guidelines, sometimes for several years after new guidelines would come out. And this was just a great example to us of, well, here's a big knowledge disconnect. This stuff is not being prescribed, or these diagnostics, the gateway, to these, are not being done because the perception is that this test will not be paid, or if the test is ordered, it will just be denied, which it often was. And so we've done things like creating kind of CMEs and webinars, and sending out Dear Doctor letters and template appeal letters that physicians could use. And we've also really tried to reach out to the payer groups to ask them to update their payment guidelines and just try and streamline this process.
Yeah. And when we were talking earlier, Ben, you had referred to, and this may be something that comes from the 2 years of COVID, but the issue about burnout in infectious disease specialists.
Sure.
How big of a problem is that? And what would be the implications for this continuing medical education, CME, around these rapidly evolving advances now in HIV?
So it's been a couple of months since I checked, but when I last checked, infectious disease was the specialty with the highest burnout rate. Probably not surprising, post COVID, but the implications of that are really significant, because another thing that Tamar and I discovered was, and we included primary care providers, including nurse practitioners, in a lot of our information gathering. We really wanted to hear not just what the specialists knew, but the people on the front line, the trusted stakeholders, the primary care providers working with patients. And we found that a lot of primary care providers don't seem confident, in prescribing PrEP or working with PrEP. And so they would refer their patients to an infectious disease specialist, not for anything really, but to just talk about PrEP. And that creates a really dangerous bottleneck. Here you have this overworked and burnt out specialty with a lot of people dropping out of it. And the primary care providers who do have both the right and the capability, they have the knowledge available, they're not feeling confident and sending these patients to this narrow bottleneck of burnt out, overworked infectious disease specialists. And I think that has really serious implications for access, and it's certainly really reinforced Tamar and my kind of belief that pushing knowledge and education about this out to the primary care level is going to be absolutely critical in helping make primary care the real front line for this.
Mm-hmm.
On a positive note, U equals U, undetectable equals untransmissible. That's something that's going to be also a huge issue at AIDS 2022, as it rightly should be, a movement of science led by community, particularly the Prevention Access Campaign. And I've really found this to be an extraordinary example of community leadership. And it would seem obvious that a backbone of the U equals U paradigm is going to be around effective diagnostics provision and availability. And I just wondered from both of your perspectives how you see U equals U changing people's understanding of diagnostics. Tamar, maybe I could start with you.
This is actually a great question, and it's the great concept or notion U equals U, because we know that with this, if you are undetectable, that means that you are not transmitting the virus, and the patients know that, and they're excited to get the treatment. But in order to know that you are undetectable, you need to be tested, right? So, and that's, make them also adherent to the testing. So to check the next time and see, whether what is their viral load, so they can prevent the loved ones from get the HIV or the community, around them, to from the transmission. So I think, U equals U changed in a way that this field that more people know the value of the diagnostics in this field. And we're really glad to see this, whether that's of course, the healthcare professionals, they knew the value, but now the patients are very well aware how important the testing is, to check whether the treatment is failing or whether they are the level is so undetectable that they can, not so undetectable that they can leave as as normal.
And at the end of the day, it's the viral load test after, obviously, super effective antiretroviral therapy that tells you that you're undetectable. So one other question about the role of diagnostics in the management of HIV and indeed a whole platform of infectious diseases. And that's back to this question of stigma and discrimination. And it strikes me that, the moment that a person either seeks or is instructed, or has an HIV test taken, or a viral load test taken for that matter, it potentially puts them at very direct risk of stigma and discrimination. And I wonder, as practitioners, how you have thought about how to protect people and how to make availability of diagnostics as easily and as accessible and without any stigma and discrimination. Are there strategies that you've seen that work, that policymakers should be aware of? Ben, what about you first?
So absolutely. I have a really good example for this, actually. In the indigenous population that I primarily work with, there is actually a very large amount of MSM behavior, especially in the teen years, but it's not talked about at all. And so it's an odd situation where there's a huge amount of MSM behavior, but almost no one would identify, as gay or trans or anything other than hetero. And to even offer someone an HIV test, especially in small communities where people all know each other, it was essentially like saying, oh, you're gay, or if it's a woman, oh, you're unfaithful. There was immediate stigma attached to this. And we tried all manner of strategies. And in that particular setting, one of the strategies that we found was the most effective was, let's just test everybody, even people that we were, there's no way this person, has it, they're, any risk at all, still test them. Because if everybody was tested, it was very hard, there was no segment of the population being singled out. And obviously, that required us in a resource limited setting, obtaining tests for people that didn't necessarily need them in order to protect the people that did really need the test from stigma. And that's a good example of the difference between, 20th century solution, which was, we've got this massive epidemic, lots of people, we've got to optimize, our resources to get the most bang for our buck, only test the people that really need it. we essentially had to be willing to expend the resources to expand that testing, even to some people who didn't strictly need it, in order to protect the people who did need it from, kind of from being stigmatized. And those kinds of solutions, being willing to expend resources that's really what's needed with this last mile. It's too easy to fall back on, oh, we're trying to be efficient and optimize, and those are important goals. But you also have to be willing to know when, we've paced ourselves for 24, 25 miles of this marathon. Now it's the last mile. We got to sprint.
And Tamar, I don't know if you could look at this question through the lens of Eastern Europe and Central Asia. Your experience as a practitioner in Georgia, where were the sort of the pain points in stigma and discrimination, and that process of someone getting a diagnostic test?
Yeah, it's a huge topic, stigma, but there are some ways. I'm a huge believer that if you put your mind into this, you can find for this, whether it's specific communities or the community at large, how to destigmatize that very specific topic. And I have a very own example also, like Ben mentioned also from his personal experience. But for me, it was hepatitis C elimination program that I was very much involved in, that we were doing for Georgia. And the prevalence of hepatitis C, unfortunately, was very high, over 7%. And that was the same issue. We had stigmatized people that didn't want to be screened. It was really hard to get people screened, even when we're offering this highly effective treatments that would cure them. The treatment that cost like over 80,000. That was what we were hearing and what everybody knew at the time. But still, people were shying away to come and get screening. But then we did this huge campaign of information sharing with the community and with the population. A lot of policymakers were coming out and saying, what does it really mean to like being infected, and not only policymakers, but I mean more like the government officials and the celebrities saying that I'm HCV infected, and they were putting on the hands like stop HCV, and it was really viral. Everybody was putting in, and then people started to come out and happy to say that, oh, I was HCV infected and now I'm cured, and that was another viral campaign that saying, oh, I was cured, so the other people can hear and come. So my point is that we really need to think like creatively. I was reading the publication the other day, and I was astonished here in United States over was in highest risk women, only 13% are taking PrEP. And when they were asked why, the response was because of stigma, not education, or not something that we hear. Also, that's that's one of the barriers for some particular community, which is really alarming, right? So we need to think creatively and see how we can do this. I said earlier in the conversation, maybe stop labeling people at risk, saying at risk versus not at risk. And to Ben's point, maybe we need to screen all.
Mm-hmm.
Get that extra mile and really,
We've got to think. Yeah, we've got to think creatively about how we tackle stigma and discrimination. And I really think that diagnostics have a key role to play there. But Ben, sorry, I interrupted you.
Not at all. I was, mass screening it was so strange. I was looking the other day. I was looking at mass screening, and all the way back in 1966 in JAMA, there was an article talking about mass screen. We need to mass screen, tuberculosis. And I was just like, oh, here we are again. Our current model trying to target, our screening for the people that we somehow label at risk, versus we got to test everybody. We've got to find the inapparent disease, is what that's called. And I couldn't agree with Tamar more. The stigmatization, really, is a huge barrier. But when everybody gets tested, then it's hard for there to be a stigma.
And it's still like here in the United States, we see the statistics. 1 out of, I think it's 7 people, they don't know they're even infected. And we keep seeing over like 30,000, I think it's 36,000 new cases every year. How that can be possible? How? When we have the highly efficacious treatment on the market and we have highly efficacious PrEP on the market.
Yeah, and we have, as we're seeing with COVID, we have, and it's a good thing that we have so many home tests now, but we sort of don't know from a public health perspective how many people are being infected and with what variants. Well, this is, as I expected, a very forthright and fascinating conversation. I wonder, have I missed anything? Is there anything that we should add that our listeners and viewers would find useful? And as we can help policymakers drive an effective diagnostics network optimization strategy?
I do want maybe all the listeners, and especially, hopefully this will be something for folks to noodle about before this conference and maybe chat about, is this whole concept of at risk. Yeah, it's the at risk labeling is so stigmatizing and it's so incorrect, in my opinion. When I looked at a lot of the research about who's actually at risk, in so many different studies that I could find, especially in resource limited settings, sub-Saharan Africa and elsewhere, your number one risk was not engaging in MSM behavior or intravenous drug use. Your number one risk was to be a heterosexual female in a monogamous relationship because of such a high level of extramarital infidelity. And I think Tamar, in my position, is essentially, if you are an intravenous drug user, of course, but if you're sexually active at all, you're at risk. You're potentially at risk. Then that's the reality. If you ever have sex at all, you're potentially at risk.
Well, it reminds me, Tamar, of these fraught negotiations after midnight in UN buildings. And from my time, what we ended up using was replacing at risk by communities that are most affected. And it didn't really capture the urgency of the moment, but it certainly helped in preventing those that would want a more sort of prohibitory and let's say more of approach rooted in persecution from taking hold. But from your side, anything in this conversation that we've missed that you think folks would find interesting?
Maybe one thing that I would add at the end is that I would love to talk to my colleagues how we can, encourage sexual history conversations between healthcare providers and patients to really help patients to speak more freely about this. And I think that we are lagging behind there as well. From my personal experience, also sometimes even I don't have opportunity to discuss with my own OBGYN some of the specifics of the sexual history, because maybe I'm perceived not at risk because I'm married with 4 children, but maybe I need to know more about what is out there, what kind of PrEP, etc. So if in my personal experience this happening so frequently, I'm sure it's happening in everybody's experience. So we have to maybe also draw our attention, how can we really help this area to advance so that we have the experience to talk about. We have the opportunity to speak with the healthcare providers on the sexual history more freely, I would say.
So as we're at the conference, what are your escape routes? Whether one is attending the conference in person or virtually, or really can't be bothered with it at all, what's keeping you sane and comfortable at the moment? Is it a book? Is it a movie? Is it a binge-worthy series you're streaming? Ben, what's keeping you sane?
There's actually I have a phrase that a friend of mine in Panama, he's a C5-6 quadriplegic. He's about 75. He's lived down in Panama, for about 20 years. And he always says, if you're not laughing, it just means you're not paying close enough attention. And that phrase really helped me out a lot, over the last couple of the absurdity so much, including a lot of the things that were horrible. There's an absurdity to it. Yeah, I've gotten kind of interested in the Dadaist movement because of this. But as outside of that, I'm very fortunate to live, right next to a very large state park, in Southern California. It still has mountain lions, still has, still wild. And when it just gets to be too much, time to open the back gate and disappear for a few hours.
And how about you, Tamar?
I love what Ben said now about, also living in California sounds so exciting. Yeah, it's one of the places that I would, would be happy to live as well, but I'm happy in Washington as well. But what keeps me sane, I think I'm very optimistic in general, and I always have a hope. And I see also so many people are so passionate that sometimes, a lot of times actually, I'm having a goosebumps when I hear people talking. They are like, just sometimes in the past, I would even wonder, how it's like their priorities, the other people's lives are priorities. And that makes me very hopeful that, together we can do it, because I'm a big believer of the teamwork. And I think that together, like in teams and kind of, collectively, we can do some great things. And we see also now lights, right? Remember, like a year ago, we almost didn't see lights, at the end of the tunnel. It was scary. But again, we saw it because, people really stood up, worked hard together, and we overcame something that we now not as afraid, which is called COVID. So
we can be a resourceful species when we want to be.
When we want to be, yes.
I like that.
Well, thank you both very, very much. This has been an incredibly valuable Cook's tour of the role that diagnostics play in infectious disease, but also really to just get a sense of the things that really drive you. So thank you both very, very much indeed.
Thank you so much for having us.
Well, that's it for this episode. Thank you to Tamar and to Ben, and thank you to Roche Molecular. Thanks also to our director, Eric Espera of Newsdoc Media. You can find us on all podcast platforms and, of course, on our YouTube channel. Don't forget to subscribe and give us 5 stars. If you are at AIDS 2022, mask up and stay safe. Have a great week and a safe week, everyone.